our pediatric patient. We have both pre-hospital perspective as well as the ER perspective. So I really think that's going to be an incredibly powerful message. Obviously, with it being the summertime and being this hot, everybody's trying to cool off, and 'tis the season. Just some kind of noteworthy comments. We're going to take the month of July off from this echo. We'll come back in August with Dr. Dinah Wallen from UC San Francisco speaking to us on the febrile infant, the 0 to 30-day-old and the 30 to 90-day-old. And then the following month, we'll have our own Dr. Robert Sapien, the leader of the Child Ready Project, speaking to us. And then we're still figuring out some things after that. But without further ado, why don't we go ahead and start with Dr. Kunderti.
Thank you so much for introducing Jeff, and thank you everyone for joining. Thank you, Lisa, Catherine, and Jeff for organizing this every month and for inviting us to talk on drowning. And I'm Nihar. I'm one of the second-year pediatric emergency medicine fellows here at UNM in Albuquerque, New Mexico, and we can begin soon. I was working last night, so if I start slurring my speech or nodding off in the middle of my talk, then it's because of that. It's not because I'm inebriated. All right, cool. Let's go ahead. So the objectives of today's talk is basically to look at the risk factors that we have been studying for the past several decades associated with pediatric drownings and their outcomes, to understand the pathophysiology and in the drowning victims and submersion injury victims, to identify the factors associated with the poor prognosis and post-resuscitation care for these victims, and to discuss the issues related to management priorities and observation and treatment in our patients. And so before going into the details of drowning, I think it would be very prudent to talk about the terms that were used, the jargon that was used in the past, and what is currently used in the clinical setting about drowning. And it would be good to know that at some point in time, we were using these terms: dry drowning, wet drowning, near drowning, secondary drowning, and until about 10 years ago, these were still used. But in the 2010 resuscitation guideline by the AHA, they recommended the use of Utstein's definitions and methods for drowning and drowning-related incidents, to improve the consistency in the way this reporting has been done, and to improve the consistency in research as well. And so according to the Utstein's guidelines, the definition of drowning refers to a process resulting in primary respiratory impairment from submersion or immersion in a liquid medium. The Utstein's guidelines also suggest that ambiguous terms such as near drowning, secondary drowning, dry drowning, wet drowning should not be used, at least in the clinical setting. The revisions of the guidelines that highlight the core data includes in studies released of drowning resuscitations in 2015. The other definitions were freshwater drowning and saltwater drowning. And in the past, the literature did emphasize the distinction between the two. And it was believed that the hypertonicity of saltwater causes plasma that draws into the pulmonary interstitium and the alveoli, that caused a lot of pulmonary edema and hypertonic serum. And then on the other side, drowning in fresh water was thought to create an opposite effect, where the aspirated hypotonic fluid passed through the lungs into the intravascular compartment, causing volume overload and dilutional effects on serum electrolytes. But then later on, the research was done, studies were done on drowning victims, and they recognized that this distinction is a lot more apparent in patients who were dead on arrival than amongst the victims who were brought to the hospital alive, so between the fatal and the non-fatal drownings. And they found that an aspiration of more than 11 mils per kg or mLs per kilogram of body weight must occur before blood volume changes, and more than 22 mLs per kilogram before electrolyte changes take place. And so because it is unusual for a non-fatal drowning victims to aspirate more than 3 to 4 mLs per kilogram, the distinction between saltwater and freshwater drowning has no longer become an important part of the outcomes in these patients. And so the other definitions would be the cold water and the warm water drowning. And theoretically, cold water was thought to benefit drowning victims by offering neuroprotection, decreasing metabolic demands, and activating the diving reflex, which is a reflex causing bradycardia, and breath holding, which is often seen in children that shunts blood to the brain and other vital organs. But the largest assessment of drowning that was a case control study between the years of 1975 and 1996, which was published in the 2000s, showed that in about 1,100 drownings that were seen, many of which occurred in cold water, there was no association between the water temperature and survival with a good outcome. And they defined good outcome as either no neurological damage, mild or moderate neurological damage. And so these terms are no longer used, and cold water is supposed to be better for survival, but in the long term, it only so affects the time of resuscitation, and we'll talk about that later. And particularly the terms that were struck out didn't show to affect outcomes, and the management essentially remains the same. And so per the AHA, currently the definitions that we're using in the clinical setting are fatal drowning, non-fatal drowning, and a submersion injury, which is colloquially used in patients with mild non-fatal drowning injuries. And so drowning, as you all know, is a very common cause of accidental death worldwide, which is almost 500,000 yearly worldwide and about 4,000 in the US. Important cause of childhood fatalities worldwide. It's been shown that in low and middle income countries, they have the highest rates of drowning, accounting for about 90% of the fatalities. And in the United States, drowning is a major cause of accidental death among patients under the age of 45, and a leading cause of death in children under the age of 5, especially in states where swimming pools or beaches are more accessible. So as you can see in California, Arizona, Florida, and all the southern states, there is quite a high incidence of drowning deaths. And in this particular map from the American Geographical Society, looking at the drowning death rates in swimming pools by state, the southern states, as we all are aware, have a very high rate of drowning victims. It's also been shown that the highest incidence of drowning occurs amongst males. It's been shown that it occurs more in African American populations and children between the age of 1 and 5. Also with persons in persons with low socioeconomic status, and again, and among the southern states in the U.S. And again, during the summer months, that's when we'll see the highest rates of these types of incidents. And as obviously everyone wants to jump in the pool and go to the beach when it's nice and warm outside. So we do see a very high uptick amongst the summer months. And the age of distribution of submersion injury is kind of bimodal. The first peak occurs amongst children less than 5 years of age who are inadequately supervised in swimming pools, bathtubs, or other liquid-filled containers, with about 7% of these incidents that could be related to child abuse or child neglect. And the second age of peak we'll typically see in the teenagers and early the young adults, so between ages 15 and 25. And these incidents occur more at rivers, lakes, and beaches. And so these, as you can see, the pool and spa deaths among children under the age of 15. It's also there's a poolsafely.gov, which is a nice website that kind of goes through different pool safety guidelines. And there's actually several state-specific regulations for pool safety that the different states, especially the southern states, came up with over the years. And in 2020, AAP came out with a drowning prevention campaign toolkit, which specifies several pool safety guidelines for pool owners that include the height of fencing, et cetera, gates, locked gates, et cetera, for accidental deaths amongst toddlers, because they can run around and jump in a pool if they're unsupervised and if there's not enough of a safety mechanism at home. And so the risk factors that have been talked about in the literature, so inadequate adult supervision is a very high risk factor amongst the toddler age groups. The inability to swim or the overestimation of abilities to swim was one of the factors. Risk-taking behavior, so intoxications and just jumping from into a shallow pool, jumping into high current streams. Those are pretty risk-taking behaviors that typically seen in adolescence. In alcohol and drug use. An underlying seizure disorder is a very big risk factor, and an undetected arrhythmia. So it has been shown that patients with long QT syndrome type 1 have a thing where they dive into a pool and they just have a period of unconsciousness and they drown because of that. And in fact, when about a year ago, a friend of my nephew's who lives just outside of Atlanta, Georgia, he drowned in a river just outside of Atlanta. And he was a high school swim team student, and a pretty much professional level swim team, was going to go to college with a swim scholarship. And they were suspecting either a seizure or some kind of intoxication, possibly, that may have caused his death. And he was like 18 when this happened. So it's pretty unfortunate, but as you can see, it can be caused by various risk factors, especially in the adolescents. And so the way the pathophysiology of drowning works. So a lot of times it starts with that period of panic when you're in the water and you can't swim, or you're unable to put your head under or over the water, which in turn causes like a loss of normal breathing pattern. It causes a period of breath holding and air hunger that subsequently becomes a struggle to stay above water. And there's reflex inspiratory efforts that causes aspiration and reflex laryngospasm when the water comes in contact with the lower respiratory tract, and that then causes hypoxia and hypoxemia, which then causes end organ effects, as everyone knows, with the hypoxic injuries to all of the organs, especially the brain. And for the pulmonary aspects, there's also this component of the surfactant washout that happens. And when that does, we do see some pulmonary edema and ARDS that develops subsequently. For the neuro, again, hypoxemia, so anoxic brain injury, cerebral edema, increased ICP within 24 hours of the incident. For our heart, there's the arrhythmias in non-fatal drownings, been shown to have sinus tachycardia, sinus bradycardia, and for the arrests, we have AFib. For the other arrhythmias, we have AFib, and for the arrests, we could have VTAC, especially in the long QT syndrome patients, which could be fatal to them. And for electrolyte abnormalities, we can sometimes see some metabolic and respiratory acidosis, although it has been shown that there are usually no major electrolyte abnormalities unless the patient drowned in a very unusual media, such as the Dead Sea, where there's a high salt content. And then you can sometimes have renal failure as well. Coagulopathy, that's something we would see, especially with the end organ effects. So the factors associated with poor prognosis are very important because it kind of determines all resuscitation time and what we can expect of these patients. And so the biggest factor that has been shown to affect outcomes in fatal and non-fatal drownings or the duration of submersion, and any duration that has been known to be more than 5 minutes is almost always leading to a poor prognosis. Time to effective BLS, that is very important, which is why, as Eli will talk about, the pre-hospital management, more than 10 minutes of time until effective BLS has been associated with a poor prognosis. Resuscitation duration that's required to be more than 25 minutes in patients has been associated with poor prognosis, although the caveat being the temperature, which we'll talk about in a sec. Age more than 14 years has been shown to be associated with poor prognosis, and also goes to the fact that they have a higher risk behavior to go into rivers and streams and lakes and stuff where it's harder to get them out. And also with the neuroplasticity that the younger children have versus older children, teenagers, and adults who do not have as much of a neuroplasticity. GCS less than 5. That is one of the poor prognosis factors. Persistent apnea and requirement of CPR in the ER has been shown with a poor prognosis, and a pH of less than 7.1 upon presentation as well. So from anything that we're going to talk about, this is probably going to be one of our biggest slides to take home for management pre-hospital and in the ER. And so the pre-hospital ED and inpatient management has a lot of different caveats that we can talk about, and Eli will talk a lot more about the pre-hospital management. So we'll come to the ER management, when one of the biggest ones is securing the airway. So giving oxygen to the patients, either low flow, high flow, CPAP, BiPAP, depending on what the patient presents with in terms of arrest and or hypoxia. So SATs more than 94% in pretty much everywhere except for Albuquerque and Denver, I guess, and other mountainous areas. So 90% is typically what we take for the higher elevation areas. And then in cases of arrest or a low GCS, consider getting the advanced airway in quicker, and in those patients who are still having low SATs despite high flow or BiPAP. Placing an NG and OG tube, as we all do after securing the airway, is important because of all of the water that the patient might have ingested. In terms of our C-spine management, it's more important in cases for shallow water diving and intoxications, especially because we are unsure what the circumstances were before the drowning event. For intoxications such as opiate and alcohol, specifically opiate, you can consider giving Narcan to the patients to see if there is a response to it. It is not something that it is something that we frequently do in a lot of unknown events leading to the drowning arrest. And so talking about the temperature, so management of temperature is important in these patients. Checking a core temperature as soon as we possibly can is important. Removing all the wet clothing from the body, and active or passive external or internal rewarming is important. So for our active external rewarming, we have we put warm blankets on. We have a bear hugger that is something that gives external heat to the patient. And we also have heating pads that we can use to help with rewarming the patient. For the active internal rewarming, we have warm humidified oxygen via our endotracheal tube. We have warm IV fluids that we can use, and in certain cases, we can always go to the extracorporeal endovascular or ECMO as well. This is probably also very important, and Jeff will probably talk about this at the end, but continuing resuscitation until we get a core temperature of 32 to 35 is important, because a very cold patient or not resuscitating a very cold patient may or may not lead to a favorable outcome. If you have a patient who is very cold in the 20s for their core body temperature, then it is still okay to continue all of the resuscitative measures until their core body temperature reaching 32 to 35. And at that point, if it's still, or if the patient is still requiring a lot of resuscitative efforts, then it may be futile. For inpatient management, there's several things to consider. So all the considerations for raised ICP and the management for raised ICP is important. For the neurological effects, we can have ischemia, edema, hypoxia, seizures as well. We could, as we discussed, have some electrolyte imbalances. So optimizing the electrolytes at that point will be important. For our respiratory, we have all of our ARDS considerations. So all the ventilator strategies that are similar to the way ARDS is treated will be important. There is no evidence currently to support the use of steroids for these patients to decrease the inflammation. And there's also no evidence for using antibiotics, although if the drowning occurred in like really gross water, and if there is or if the patient were to have a pneumonia that occurs following non-fatal drowning, then we should consider a high suspicion for waterborne pathogens such as Pseudomonas, Aeromonas, Proteus as well, and covering for them would be important. Not, again, this is more of the inpatient setting, not in the emergency setting. And as we talked about, the surfactant washout that occurs, but there hasn't been any good evidence to suggest that the use of surfactant would be important in these patients. Some patients can also have hypoxic cardiomyopathy as well. And there's also hypotension and from what they call cold diuresis that can occur. So blood pressure optimization is one of the biggest things that is done for managing raised ICP, but not having hypotension is crucial in these patients. And for disposition of patients, most of the non-fatal drowning victims are symptomatic and are hospitalized, and their disposition is fairly easy. And also the non-fatal drowning victims who are arrested in the field and were brought back by shorter resuscitative efforts are also pretty easy to disposition. And you have the submersion injuries, which are a little bit trickier. And there have been studies from the late 90s in the Journal of Pediatrics. One of them was on 75 PEDS patients, and it seems like all the patients who developed the symptoms did so within about 8 hours. And so typically symptomatic patients are admitted to the inpatient unit until the symptoms resolved. And most of the time the symptoms are symptoms of shortness of breath or the requirement of oxygen in these patients. I do not believe they talked about chest x-ray findings and whether just having a positive chest x-ray finding for mild edema is considered in symptomatic or reason enough to hospitalize, but the patient is truly having symptomatic presentations, then they should be hospitalized. And for those patients who are not or who are mildly symptomatic or come in with a history of a submersion injury, it could be prudent to get EKGs, electrolytes, renal function, coags in those patients, and getting a chest x-ray towards the end of the observation period if the patients are asymptomatic. Put them on a continuous cardiac monitor, put them on a pulse ox, and get that x-ray later on. An earlier x-ray hasn't been shown to show a whole lot, so if you're going to observe a patient after a submersion event for 8 hours, doing so at the end of that 8 hours, and it's 8 hours from the time of the drowning event. And we actually recently had a couple of kids in the ER who had very mild submersion injuries, submersion injury events, and they just got that observation period. They got the chest x-ray about 7 hours after their event, and they were able to get discharged, and they were initially mildly symptomatic, and then they became asymptomatic later on. Right, so I'll stop here and I'll hand over to Eli. I wasn't monitoring the chat, but if there's any questions, comments, I'll be glad to.
Yep. One comment to everybody. You touched on the drowning and C-spine and trauma, and actually just 2 weeks ago from the ACEP Pediatric Committee got a request from the National Trauma Committee that they're trying to redefine are all drownings trauma, and should they include a trauma workup. And I think, as you so succinctly explained, really, I think that's an issue with our teenagers in particular, because teens are stupid, especially stupid guys, you know, diving into pools, being drunk, you know, yeah. Anybody who's obtunded when they, you know, come to your ED, sure, you need to think about it. But for most of our 18-month-olds who fall into a bucket or in the bathtub, yeah, I don't know that we need a trauma team sitting there, you know. And just hearing what you said is so important, because I admit it, we just had a drowning last week, and I admit it, the kid was a little symptomatic. I love getting a chest x-ray as soon as they hit the door, and then getting a repeat one 6 or 8 hours later. And I don't know that they really need that first chest x-ray. Like you said, I could just watch the symptoms and decide, rather than irradiating the kid twice.
I have another question for our pre-hospital people. I know that there is a push to not C-spine people. And as Jeff was saying, your stupid teenagers probably need it until they can come in. But what about the little toddlers? Do you think they need C-spine until they come in? Do you think they need to collar putting on prior to arrival, or can we just presume that there's not the amount of force and trauma?
I believe a lot of them. Sorry, you can go ahead.
I'm just sorry, if you were going to answer that. I will tell you, if you're in Albuquerque, depending on the circumstances, we will immobilize them simply because of the way that we strap them into the gurney. So they will come in with some form of immobilization. It won't be a collar, but we will keep them immobilized.
Thank you.
And with that, let's turn things over to Eli Oquendo. Eli is one of our paramedic captains here for Albuquerque Ambulance, has a wealth of experience, both personally and professionally, and look forward to him sharing his information.
Okay, hopefully everybody's able to see the screen there. So there's not a lot of education pre-hospital for the dealing with drownings, which is amazing. And here in the desert in Albuquerque, we actually deal with quite a bit. So some of the slides you're going to see are going to repeat what Dr. Conducci said, but also looking at it from the perspective of the pre-hospital provider. So we think about submersion or immersion, and Dr. Berendt mentioned I have personal experience having suffered both of them as a child, but thankfully I'm still here. But when you're in that situation, you get a sense of the circumstances, the feelings, and everything that surrounds that, both from the victim as well as family. The difference between warm water and cold water, we're going to show a couple of cases you'll see in the slide here. Hennepin County up in Minnesota dealt with one particular case with about 5 or 6 victims in one car that went into a retention pond, and we're going to see some of the times that survival was still achieved. You'll notice down in the bottom right, case reports up to 83 minutes with survival. We also think about the trauma or other factors that may have precipitated it. We've mentioned a lot about the males in particular being susceptible to this because of the risk behaviors, and then resuscitation. The next slide. So like Dr. Kundratman mentioned, there's not really good numbers. WHO has reported approximately 250,000, but the thought is perhaps closer to 400,000. And a lot of it has to do with the training, the supervision, and mostly where these other cases are taking place. And we're going to focus more on the recreational, but we have seen bathing drownings, of course, about 5%. These are the little ones. There are males who are susceptible because of the risk behaviors. And in this particular slide, dealing with a pool, because the case we're going to talk about was in a pool, you'll notice here in New Mexico, we actually have very specific standards for swimming pools. Any outdoor swimming pool, whether it's in ground, above ground, hot tub or spa, is supposed to be surrounded by a barrier with no more than a 2-inch clearance from the bottom of the barrier to prevent anyone from being able to get into the tub unsupervised. However, you may see these sort of pop-up swimming pools that are filled with water and they raise. Those don't necessarily fall into this category, and so this is where we may see some of our drownings. In fact, the case that we're going to talk about in a little while. But there is specific regulation to help prevent the pediatric drowning. Some of this, as I mentioned, is going to be repeat. It's kind of found that the majority of non-fatal drownings have less than 30 milliliters of water in their lungs, whereas the fatal, you have quite a bit more. And again, speaking from personal experience and also what the literature says, you have that reflective closing of the epiglottis when you swallow something in the wrong area. And so you immediately start to close off, which is very protective. But over time, as the patient becomes unresponsive, the longer they're in the water, this reflex is going to start to relax and they're going to start opening up. And this is where they're going to be able to ingest the water, both into the lungs as well as the stomach. And we'll see how that affects at times. So the mechanism of action is really, as was mentioned, hypoxemia and hypercapnia. It's good that we don't use all these other terms, wet drowning, dry drowning. It really confuses it. We really want to focus on what's taking place. This is a hypoxic arrest, and we want to take care of that airway, and especially when we're dealing with the younger ones who generally have fairly good hearts. We really want to focus on what we need to do immediately. The 3 possible outcomes that we pre-hospital are thinking about when we get one of these calls is the death, survival with brain damage, survival without brain damage, and of course, the quicker we get there, the more likely we'll get that number 3, and that's what we're trying to get. So some of the things that we know, as was mentioned, when you take in all this water, especially the salt water, dirty water, it is going to irritate the bronchioles. You'll get that coughing reflex, inflammation, bronchoconstriction. We are thinking about the disruption of surfactants, ARDS, especially with the salt water. If you ever look at lifeguards, particularly ocean-based lifeguards, you'll see this effect in a lot of their resuscitation efforts. We'll show a picture in a little bit as to what this might look like when someone is taking in a lot of this salt water in particular, but of course, any water is going to cause this irritation. You'll damage the alveolar capillary interface. You have that inflammation, you get that pulmonary edema. And here we can see a little bit of what's taking place. And you'll notice down on the bottom, the Wilderness Medicine Training Center, because not every one of these drowning cases actually makes it to the hospital. I will tell you, here in Albuquerque, we do quite a few drownings, which is surprising considering that we're in a desert, but the majority don't get to the point of transport to the hospital. So we may see certain things again and again. For example, here, a lot of our child abuse cases that have resulted in drownings, deliberate drownings, successful as it were, do not get transported, but we are there first, and we're getting to see some of the trauma related to it and some of the causes of the death. But for those who have aspirated, of course, the washout of surfactant doesn't allow the lungs to continue to open. So you're reducing that ability to bring in the oxygen and get out the carbon dioxide. That's important for us because, as you notice at the bottom of the slide, one of the things that we want to provide very quickly is positive pressure rescue breathing to help open up that alveolar surface. The other thing that can happen, and again, particularly with the salt water, as you'll notice here, it damages the interface, causes inflammation, thickens the interstitium, but it also causes plasma to leak into the alveoli. And when the surfactant mixes with the plasma, you start seeing this foam that's issuing from the patient's mouth and nose. So if you look at this picture, it's a little bit hard, you can't fully see it, but if you look at his mouth, you'll see that this patient, and this is on a beach, has aspirated salt water. He was down for some time, and you'll notice that foamy substance coming out of the mouth as they're doing compressions. So for us pre-hospital, one of the things that we're looking at is breathe through the foam. And the reason is this is coming from the lungs. We're increasing the pressure there. It's actually helping this to come out of the lungs and provides for oxygenation. If you think of the CPAP or BiPAP, which was mentioned earlier, what we're trying to do is push through the water so that we can still get that oxygen exchange. Well, with the positive pressure ventilations using a BVM or even mouth to mouth, this is exactly what we're trying to do. So when we see foam, we're going to try and breathe right through it. You go down a little bit under the picture though, if you see vomit, now that's coming from the stomach, and of course we don't want to aspirate those contents. Considering the C-spine precautions as necessary, there we'll try and roll and suction. We don't want to be breathing through that. We want to make sure that we can maintain or create a clear airway. And if you have compressions, rescue breathing, and you get a return of spontaneous circulation, you get a pulse back, we stabilize them, and then we transport as quickly as we can. So again, if you rescue a drowning patient and they're unresponsive with no pulse, even in the water, if you're doing a water rescue, you can begin rescue breathing and compressions. For example, if you have a surfboard or any kind of hard surface that you can utilize, the lifeguards are trained to do this. They used to slide in the life backboard under the patient, and you can begin the resuscitation efforts in the water as you bring them out and continue there. Even if in cold water, 30 minutes or 90 minutes in the ice cold water. I come from the Northeast, for example, Hampton Beach, New Hampshire. In August or June, average temperature is about 58. You could go down into the 40s. So very cold water, if you start drowning there, we talked about the perhaps cardioprotective effects of this very cold water in a drowning victim. So we may have an extended resus effort in that case. Now, if they're awake and they're coughing or wheezing and they're tired, well, we're going to monitor, we're going to give oxygen as needed, and then we're going to treat them in an anticipatory manner, see what's happening. It's been mentioned you want, when you transport to the hospital, to observe them 6 to 8 hours, see if there's any development of problems. And you'll notice the mention of ECMO here, and Dr. Kunduri mentioned this, and this goes back to the case that I mentioned up in Hennepin County. So the 5 or 6 victims that were found, it took time to find all of them. They weren't sure of everybody who was involved, but you'll notice here the 6-year-old female was submerged for 26 minutes. She was asystolic. She had all the pre-hospital interventions. You'll notice that she was intubated. Here in New Mexico, we do not allow pre-hospital providers to intubate children 12 and under. So we use other methods, perhaps an LMA or the BVM. But she was placed, if you go down to the bottom, on ECMO at the Children's Hospital there with good neurologic recovery. Dr. Kunduri mentioned it's not exactly sure why or how this may be effective, but what this particular case brought up is that with the ECMO taking over the heart-lung functions, they were also able to utilize that to maintain hypothermia and to provide exogenous surfactant, which is a thought that may have been helpful in this particular case for her resuscitation. Now, her case was 26 minutes. In our next one, we'll notice this is the same event. It was 1 hour after extraction with good neurological recovery. And this one was also placed on ECMO. And again, it's not very specific how ECMO is beneficial, but these two cases demonstrate that there is a possibility. It's important for us as pre-hospital providers with our interaction with the hospitals, because this may inform decisions as far as transport. Should we be transporting to an ECMO-capable hospital versus one that it's not, if there's a thought that this is going to be beneficial? Of course, this is something that we need with the interaction with the hospitals to develop a plan so that we are able to make that decision pre-hospital. So this is the case that we're going to consider. It was a 4-year-old male. And here in Albuquerque, New Mexico, we use what are called MPDS codes. This is how we are dispatched with an idea of what's taking place. So you'll notice this was originally coded as a 9 echo. So the number 9 for us is a cardiac arrest. Echo, whenever you see that, that means someone is in arrest. There's different types of arrest. But that's important because once we get that designation, it determines the resources that are going to be allocated to that particular call. It was initially coded as a 9 echo cardiac arrest, but when more information was provided, it was changed to a 14 echo, which designates a drowning who is in cardiac arrest. And again, that's very specific for us because of the resources we're going to allocate. In this particular case, you'll notice that requires 1 rescue engine. So the fire department is going to send a rescue ambulance with 2 paramedics. The engine has 4 providers, usually basic or intermediate level. The 7-8 is the captain for the fire department. So he's my level. So they're trainers and on-scene supervisors. They'll get at least 1 transport ambulance from AAS with at least 2 providers. Sometimes based on the configuration, they may have 3. You have an AAS ops supervisor, who is our version of the 7-8, who is also going to respond. In this particular case, I was that supervisor. And here in New Mexico, in particular in this area of Albuquerque, we have the consortium doctors. These are doctors trained in our EMS guidelines. They're very well qualified. They know our form of work and they oversee us directly. So many times they will show up on scenes and they will work with us, which is beneficial, obviously, in certain cases. In our case, the family had been out in the pool in the late afternoon. All the family, there was about 3 children and the parents. After a certain time, when they finished their activities, the parents entered into the house. They thought they had all the children, but as can often happen with a lot of little kids, they went inside and noticed after a certain amount of time that one of the children was missing. The thought was, from the information we were able to gather, was perhaps somewhere between 10 and 15 minutes. Of course, we always know that in these circumstances, time frames are not exact, but that was the best estimate that they could give us. When they realized that the child was missing, the initial thought was the pool, and sure enough, they went back to the pool and they found the step ladder had been placed again in this inflatable pool, and they found the child floating. They activated 911 immediately. It was unknown, and the family began compressions. Again, because of all the emotions that are involved, it's sometimes kind of hard to get all the information. But they were able to indicate to the initial providers that there was no medical issues with the child. The fire department was the first one to arrive on scene. So that was the engine and the rescue. So that's 6 providers on scene, and they initiated treatment. No trauma was noted on the patient. There was no signs of that. And the patient was expelling clear fluids. So they began to immediately assign all the different roles in a resus effort, and the lead paramedic takes control. They initially found the patient to be in a sinus tachycardic PEA about 119. They were apneic. And this child weighed approximately 15 kilograms, so rather small. So one-handed CPR was initiated, BVM initially with an OPA, and they placed oxygen and end-tidal. Once their supervisor, their captain, arrived, he began to oversee the call, directing both treatment and med administration. They placed the LMA during the resus. They got an IO for access, began giving fluids and epi administration. One thing, especially for the hospital-based providers who oversee pre-hospital providers, notice at the end, we mentioned simplification of dosing is always desired. Here in Albuquerque Fire Department has gone to the Certidose dosing vials to make it very simple. Under these circumstances, because you do not do as many drowning cases, it's not like a normal cardiac arrest where we do so many. We're very well into the flow of the treatment, the medications, the dosing. With the pediatrics, it's very different. Super important to get better simplification of the dosing and the running of these type of calls, better training, so that when we face these very rare cases, we're much quicker in our treatment. The patient was worked on seeing for approximately 15 minutes, and ROSC was finally achieved after the epi administration. At that point, before it used to be you run and go as soon as you get ROSC. Here now we stabilize the patient, make sure that we're not gonna lose pulses. We prepare everything for transport. We always do a radio report, an alert to the hospital, in this case to UNM, specifically the pediatric department, so that they have their resources available when we arrive, and it's an immediate transfer of care. We also brought along families so that we can provide more information to the hospital staff at turnover, information that over the time they're able to gather again mentally and provide. Once we arrived at the hospital, the patient was still unresponsive, but now he had a strong or weak, heart rate of 107. He was still being bagged at 24 times a minute. He had an end-out of 11, which, while not good, it still was stable for the patient. I did find out eventually, after several days, the patient did die. But of course, that's oftentimes what's going to happen, especially with the longer or extended downtimes. But you notice all the things that was done pre-hospital in order to give them the best chance of survival. So many drownings, I mentioned here in Albuquerque, have not been transported due to the nature. Unfortunately, a lot of them are child abuse, and we get to see a lot more that we don't necessarily share the information with the hospital simply because we're not transporting them. Early intervention, however, is known to be really beneficial, super important for the accidental drowning victims. Early activation of EMS, because you're going to get a wide array of services that's going to be able to provide consistent care, hopefully leading to the resusc. And the constant teamwork between both of the agencies. And this is both the pre-hospital agencies, but also with the hospitals as we turn over care. So that's the last of the slides. If anybody has any questions.
A couple of comments, Eli. I mean, one, I so appreciate both your and Nihar's presentations. I think it's so important to, again, bring up point of view and point of access. Where are these kids coming to, and pre-hospital versus in the hospital. The one thing that I really wanted to stress in particular was, for those of us who are old, who have done resuscitation and learned ABC, 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 and then, 10, 15 years ago, all of a sudden it was CAB, CAB, CAB. When we're dealing with drowning, it's all about oxygenation. So again, it's kind of one of those situations where really think about, hey, they're foamy. Like you said, we need to get oxygen in. And then just kind of some superfluous comments. As far as I know, I remember when, surfactant was first coming out in the late 80s and the early 90s. I know there have been attempts of utilizing it in drowning victims. I know specifically there was success with a 25-day-old infant who drowned, and they gave surfactant. And that kind of just makes a little more sense that it would work in a neonate, maybe. I don't know, but I'm not convinced that there's really been any great data to show that it's been a benefit, even though we know that surfactant is being washed out in these patients. And then finally, especially for those who aren't part of our Albuquerque area, UNM pre-hospital care is the only place in the United States that is doing pre-hospital ECMO. It is only approved for adults. It is not approved for kids, but we do, our critical care ER team has had incredible success, 50-60% survival, much better than I expected for doing in-field ECMO and then doing it here. Most hospitals don't have ECMO availability. Within Albuquerque, I know UNM and Press does, but for pediatrics, but I don't know of anybody else who does it in the state.
That's correct. There's only those two. And I'll emphasize again that with UNM, with the consortium doctors, I don't think that everybody has that availability. So all of the fire departments here, their medical directors are consortium doctors, and their intimate knowledge of our protocols or our guidelines, really, because we are given flexibility, is so important, as well as the fact that, as I mentioned, they oftentimes will show up on scenes. So we have in-person consultations available to us. They don't take over the scene unless we ask, but that has really improved our ability to take care of a lot of these patients.